Good morning, ladies and gentlemen. I am Professor Ashar Ahmed Mashoor, and today I am going to deliver a talk on skin aging. This is the first lecture of the section of aesthetic dermatology. Since I have completed all the other lectures of um, this section, so this is the last lecture of the section of aesthetic dermatology. Introduction. Aging is inevitable in every organ system, yet no organ conveys to the outside world an aged appearance as does the skin. So the aging on the skin is obvious to everyone, but the aging in lungs, liver, kidney will not be obvious to the external world. The implications of skin aging are broad and include the cosmetic concerns of appearance as well as medical and social concerns. An aged appearance, especially the face, results from confluence of aging bone, that is the structural aging, the aging muscle, aging fat, and the aging skin. Bone aging is characterized by excess resorption leading to volume and support loss, particularly seen around the orbit, around the nasal orifice, and at the jawline and chin. Muscle aging can present as hypertrophy or atrophy of particular muscle groups. Then the fat atrophy or hypertrophy also occur. The deep fat atrophies always, while the superficial or subcutaneous fat may hypertrophy or atrophy. In this lecture, we describe the clinical features of both intrinsic and extrinsic aging and the molecular mechanisms of both types of aging and little on the cosmetic, medical, and social implications of the aged skin. I have tried to keep this lecture as simplified as possible, removing the unnecessary molecular details. The clinical features of skin aging, the intrinsic aging. First, intrinsic aging is also known as the chronological aging, natural aging, or just aging, which occurs inevitably, continuously, and gradually in all skin types over the individual's lifetime. So, this is the kind of aging which we all will encounter no matter what is our external environment and how much time we are spending outdoors. The intrinsic aging is observed in its purest form on the upper and inner aspects of arm, hip, buttocks. These are the sites which are typically protected from ultraviolet light, so the external aging has no influence on these areas. The salient feature of intrinsic aging is the dryness, the homogeneous color, skin atrophy, fine wrinklings, and lack of telangiectasias or dyspigmentation. Dryness, atrophy, and fine wrinklings are the three features which are common in both intrinsic and extrinsic aging, while dyspigmentation and telangiectasias are not seen in intrinsic but seen in extrinsic aging, as I will describe it further. The intrinsic changes are typically more prominent in light skin tones compared to the skin of color. Extrinsic aging. We will describe the extrinsic aging in two categories, the aging in white skin and aging in skin of color. Extrinsic aging is commonly referred to as the photoaging and results from the damaging effects of ultraviolet radiation although other factors like tobacco smoking, pollution, psychological stress, poor sleep, and high glycemic index food and fizzy drinks also implicate. The hallmark features of extrinsic aging are the rough texture, the dryness, the dyspigmentation, fine coarse wrinkles, and telangiectasias. Hyperpigmentation include the solar lentigines, the patchy, irregular tan and brown discoloration, which can be diffuse. Generally, a patient of age patient will come to us with a complaint that they have gradually developed a dull skin. And on close examination, you cannot find any clear melasma or other patches. So it is just the overall dullness or dyspigmentation which is seen in aged skin. There are areas where the skin pigmentation is lost. So there are also areas of hyperpigmentation and depigmentation. Extrinsic aging is best seen in areas which are exposed to ultraviolet radiations like face, upper chest, décolleté, extensor forearms, dorsal hands, and neck. And these changes are always asymmetrical. So it is not necessary that both sides have the same findings of extrinsic aging. For example, if you are driving with a right hand drive, then your right side of the face will take more brunt of the sunlight as compared to the left side and will show more signs of the aging. And if a person is not driving and always sitting on the second or the co-driver's seat, then the left side will be more affected. Aging in skin of color. So skin of color is a broad term used for the skin of many ethnic types, which include the Asian skin, the Latin American skin, and the African skin. In general, photoaging in skin of color manifests differently compared with the white skin. The inherent protection due to increase in melanin in darker skin types confers more protection from extrinsic photoaging. So the melanin present in skin of color is more protective. In addition, these skin have a thicker dermis compared to white skin, increased convolution of the dermal epidermal junction, increased fibroblast number and activity, which is notably seen in African and in the Chinese races. That's why these skins appear to wrinkle less as compared to the fairer skin. In general, photoaging in dark skin is characterized by early finding of pigment irregularities, then the findings of thinness, atrophy, and wrinkles. Wrinkling does not typically become apparent until after 30, 50 years and much less extent as compared to a 50-year individual with a fair skin. A manifestation of photoaging in skin of color is dermatosis papilosa nigricans, which are the small seborrheic keratosis-like lesions which are noted particularly in Asian and African races. So this is the dyspigmentation, which as an extrinsic sign of aging. So you can see the dyspigmentation in Eastern Asians, in Indians, and in African. And these are the DPN, which are the small seborrheic keratosis-like lesions. The extrinsic aging variants. There are two main clinical variants of extrinsic aging, which are recognized and described. The first is the atrophic photoaging or atrophic extrinsic aging. This is characterized by individuals with numerous fine wrinkles, facial wrinkles, epidermal atrophy, telangiectasias, redness, focal depigmentation, or hyperpigmentation. In this variant, there are predisposition to development of precancerous and cancerous lesions. So the presence of fine wrinkles is a hallmark of development of precancerous and cancerous lesion, fine wrinkles and atrophy. The steady correlation between fine facial wrinkles and presence of BCC was observed, and it is observed that patients with these kind of wrinkles, there are increased chances of development of basal cell carcinoma. Then the second variant of extrinsic aging is hypertrophic photoaging, which is characterized by some protective hyperplasia, tanning, homogeneous color, lentigens, epidermal thickening. Rather than fine, they are coarse wrinkles and less tendency to develop skin cancers, mostly in Fitzpatrick 3 or 4. So, in hypertrophic type of extrinsic aging, there is hyperplasia or thickening of the dermis or the skin and coarse wrinkles. While in atrophic type, there is atrophy of the skin and fine wrinkles. So, the fine wrinkles are associated with cancers. Coarse wrinkles are not associated with cancers. The examination of the molecular features of atrophic and hypertrophic photoaging in aged, matched, control subjects have demonstrated the same degree of collagen damage between the two clinical variants. However, the hypertrophic photoaging, there is more elastotic damage. Hypertrophic photoaging occur in younger subjects compared to atrophic photoaging. This is another reason of more chances of skin cancers in atrophic photoaging. Extrinsic aging is always superimposed on intrinsic aging, since intrinsic aging is a gradual ongoing process seen in all the skin, whether sun exposed or non-sun exposed. Smoking and skin aging. The smoker phase is characterized by wrinkles that are radiating at 90 degrees from the lips and the eyes, with a gaunt features, atrophic features, uneven complexion, and grayish skin hue. In skin of color, hyperpigmentation around and within the oral cavity may also be observed. The mechanism of tobacco smoking leading to facial wrinkles is poorly understood, but is thought to involve the tobacco's deleterious effects on the elastic fibers and on the new collagen synthesis and on the matrix metalloproteins induction, similar to the effects seen by ultraviolet radiations. The effect is induced by generation of reactive oxygen species, direct effect of nitrosonicotine, and reduce blood flow within the microcirculations. Some other clinical features of aging include the cutaneous nodular elastosis with cyst and comedons. Cutaneous nodular elastosis with cyst and comedons is described by Favre and Ricochet, and also known as the Favre and Ricochet syndrome. It is also a sign of extrinsic aging, characterized by open cyst and comedons on the lateral malar cheeks, periorbital region, and more often seen in smokers. The treatment modalities have not been standardized but include comedon extraction and surgical removal with ablative laser therapies. The skin sign or the aging signs of neck. Photoaging of the neck is quite different in most cases from that of the face, even in the same individual. The poikiloderma of Civet is the term. The Civet is a term used to describe the findings of extrinsic photoaging of the lateral neck in white skin characterized by reticulate redness and dyspigmentation. This condition is, however, not seen in skin of color. So, reticulate telangiectasias or redness with dyspigmentation is one of the signs of aging neck in white skin. The skin of the nuchal region behave a little differently from the lateral neck skin. The coarse wrinkles, as you see in the picture, bronzed and sallow appearance, minimal telangiectasias are all the features of hypertrophic extrinsic aging. Laser and light-based therapies are useful to improve this condition cosmetically. Idiopathic guttate hypomelanosis is a term used to describe the hyperpigmentation that presents as a small single or numerous white macules, most pronounced on the extensor surfaces of both upper and lower extremities in light and darker skin types. These lesions are likely attributed to the irreversible ultraviolet irradiation injury to the melanocytes. The Bateman purpura. Bateman purpura, also known as the senile purpura, are ecchymotic patches on photodamaged extensor surfaces of arms and dorsal hands, appear with or without anecdotal trauma. So without trauma can also occur. It is striking that these lesions are not seen on the flexor aspects or any sun-protected site. The resolution is slow and condition is recurrent. The anecdotal trauma and anticoagulant medication like aspirin, heparin, warfarin, and other antiplatelets or oral topical corticosteroids may contribute. Otherwise, this is mainly due to the atrophy of the dermal collagen, supporting the blood vessels. No good therapy is available. Judicious sun protection starting early in the life may mitigate against the condition. Then menopausal skin aging. It is observed that skin age in menopausal population more than the premenopausal population. And this offers an insight into the role of hormones that play in the aging skin. Estrogen is known to exert its action on skin through estrogen receptors. Estrogen have effects on both epidermis and the dermis. In the epidermis, they cause increased thickness, hydration, and increase in surface lipid content. So hydration and thickness. Similarly, in the dermis, it results in increased hydration, increased glycoaminoglycan content, and increase in collagen. So estrogen has both the effect of hydration and increased thickness in epidermis as well as in the dermis. Menopause is associated with increased dryness because of decrease in estrogen, decrease in skin elasticity, and decrease in dermal thickening. So estrogen-based treatments are believed to be beneficial for improving the appearance of photo-aged skin. Women who are taking the estrogen replacement for menopausal symptoms are observed to have a better skin appearance also. Dermatoporosis is referred to the chronic cutaneous syndrome associated with advanced age and sun exposure, in which the integrity of skin is severely compromised. So dermatoporosis is a term used for the aging skin syndrome. In this syndrome, skin appear atrophic, lacerated, bruised, and bleeds. There are cosmetic implications of these findings. The emphasis in this syndrome is on the loss of functional integrity of skin to confer protection from the surrounding atmosphere. Age-associated functional impairment in skin in dermatoporosis is similar to osteoporosis in the bone. Hyaluronic acid, which is the major glycosaminoglycan in the skin, is decreased along with its surface receptor CD44 in dermatoporotic skin. There are 4 stages of dermatoporosis. In stage 1, there is pronounced skin thinning. There is purpura, stellate pseudoscars. The Bateman purpura is represented as a sign of type 1 dermatoporosis. In type 2 dermatoporosis, in addition to the above sign, there is laceration, resulting from cleavage between the epidermis and dermis. In stage 3, the lacerations are numerous and extensive, sometimes involving the entire extremity. There is delay in wound healing as a pronounced feature. In stage 4, there are hematomas, resulting from extreme skin damage. Genetics of skin aging. So you must have observed that everyone is not aging similarly. So this aging, the intrinsic aging, is dependent on the particular genes, and there is a great diversity in skin aging even within the families. It seems that the genes regulated by exposure of skin to UV irradiation or those associated with particular phenotypes such as light complexion traits, blue or green eyes, and light hair could be more implicated. And one of the most popular gene which is implicated is the MRC1 or melanocortin 1 receptor gene that maps on the chromosome 16 and the gene is located on surface of melanocytes. Sorry, the receptor is located on the surface of melanocytes. When the receptor is activated by the presence of gene, melanocyte produced eumelanin, which is the black pigment, and it is UV protective. In contrast, when the receptor is blocked, the pheomelanin is generated on sun exposure, which is not UV protective. Polymorphism in MCR1 gene receptor observed in population with respect to hair and skin pigmentation. This is responsible for normal variability, but still remains a significant risk for severe photoaging. The author postulated that pheomelanin is a potential source of reactive oxygen species, in contrast to eumelanin, which scavenge the ROS, thereby leading to rest wrinkling. The intrinsic aged skin, there is a trend towards hypermethylation across the genome. Aged and sun-exposed skin tend to be hypomethylated and hyperacetylated, leading to changes in gene expression. Grading and measurement of skin aging. Histopathology of skin demonstrate the hallmark finding of solar elastosis, which is graded from 1 to 3 on histopathology specimens. It is quantifiable along with the extent of dermal collagen fibril fragmentation and disorganization. The quantification of photoaging is desirable as it may lead to important clinical information on risks of actinic keratosis and cancer. So in type 3 type of solar elastosis, there are more chances of having actinic keratosis and skin cancers. This histopathological quantification of skin aging is not practical clinically. So to quantify skin aging for purpose of patient care, photonumerical non-invasive tools have developed, and they employ a scale of 0 to 8 with illustrated photographs and found to be superior to the descriptive scale that does not involve the photographs. It specifically assess the clinical features of wrinkling and dyspigmentation, where 0 refers to no photo damage and 8 refers to severe photo damage. So patient can pick up, or you can observe that at which scale the patient lies. This scale does not discriminate between hypertrophic and atrophic variants of photoaging. Also, when utilizing the photonumerical scale, it is critical that user is aware of the wrinkles caused by cutaneous aging as opposed to those due to underlying structural defects like fat pad atrophy and skeletal absorption. Another limitation in this scale is that this scale does not take account of skin of color. So some modification in photonumerical scale is done with correlation of age and history of cigarette smoking, the anatomical sites, with scales including photographic global assessment of forearm sun damage and 5-point dynamic platysmal band photonumerical assessment scales. So the further description of these scales is beyond the scope of this lecture. So you can study it and you can Google it for more detailed information about these platysmal band photonumerical scale and the forearm sun damage scale and the simple photonumerical photo damage scale. The pathophysiology of skin aging. So this is a little difficult section, but I have tried to keep it as simple as possible. The skin aging is apparent in both epidermis and dermis. However, the changes observed in extracellular matrix, particularly the dermal collagen and elastic fibers, are the hallmark of aged skin and reasons of wrinkled appearance. The type 1 collagen is the most abundant protein in the dermis and account for 80% of the dry weight of the dermis. The degradation and decreased production of new collagen result in skin aging. This is a simple definition. Though there are differences in pathophysiological processes between the intrinsic and extrinsic aging, but both processes culminate in the final common pathway, and that is the decrease in collagen production or increase in collagen degradation. Extrinsic aging is always superimposed on intrinsic aging, and the extrinsic aging tend to be more pronounced compared with extrinsic aging. Reactive oxygen species, which are produced as a result of extrinsic aging, cause direct cellular damage to the cell wall, lipid membranes, mitochondria, and DNA. But the molecules that derive and catalyze the complex signaling cascade in aging skin lead to fragmentation of the formed collagen and reduced new collagen formation. Ultraviolet radiation, damage, and episodic exposure. In skin cell, inherent energy in UV radiation is converted to ROS, which initiates the cascade of biochemical reactions. As little as 1/10 of the minimal erythema dose of UVB radiation from 280 to 320 nanometer leads to statistically significant cellular and molecular response that deleteriously alter the dermal collagenous extracellular matrix. So little of the UV exposure is sufficient to start the extrinsic aging. It is envisioned that lifetime exposure of UV light causes accumulation of dermal damage, brings about more photoaging. The reactive oxygen species are generated in skin cell as a result of oxidative stress due to direct exposure to ultraviolet radiation. Oxidative inhibition of protein tyronase phosphate and consequent activation of growth factors and cytokine receptors occur rapidly following ultraviolet radiation. These pathways, including the mitogen activated protein kinase, ERK, P38, JNK, with controlled growth, differentiation, and stress responses in skin cells. So, mainly the reactive oxygen species, then the inhibition of protein tyronase phosphate, PTP, and then production of cytokines and further receptors like ERK, P38, JNK all affect the collagen disruption and decrease in synthesis. The MAP kinase pathway induces transcription factor AP1, which is critical in photoaging process because it's a major regulator of methyl metalloproteins. So MAP kinase pathway, AP1 and methyl metalloproteins you should also remember. The MMP1 is the key enzyme that is specifically able to initiate collagen fibril degradation. Once cleaved, collagen fibrils are further degraded by MMP3 and 9. So the collagen fibril degradation by methyl metalloprotein 1, 3, and 9, coupled with imperfect repair over a lifetime of sun exposure, is a proposed key mechanism giving rise to clinical phenotype of skin wrinkling. Other environmental influences in skin aging. The skin exposome refers to the totality of environmental exposure over a lifetime that modify or induce skin conditions include photoaging. Other than ultraviolet radiation, it is smoking, traffic-related air pollution, hormone stress, nutrition, psychological stress, lack of sleep that all contribute to aging. A direct link with dyspigmentation and wrinkles and airborne pollution is also established. The proposed mechanisms again is generation of ROS and production of organic metals and chemicals, leading to inflammation and collagen degradation by all the other environmental hazards. The collagen fibril fragmentation. As explained, type 1 collagen is most abundant dermal protein. It forms fibrils, which are associated with several additional extracellular matrix protein and proteoglycans. These fibrils serve as a structural support to the skin and as a dynamic scaffolding to which the dermal cells adhere and interact. Fibroblasts synthesize, secrete, and promote the assembly of all the components of collagen fibrils. Cross-linking among the fibrils is absolutely necessary for mechanical stability of these collagen fibrils. The normal turnover of skin collagen is very slow, with average half-life of 15 years. As skin ages, changes in protein that regulate the collagen homeostasis occur. The dermal fibroblasts secrete signaling protein called as CCN1, and CCN1 level becomes elevated in aged skin. Elevated level of CC1 impair transforming growth factor beta signaling and subsequent collagen formation. So elevated CC1 level is not good. Due to the inherent mechanical properties, intact collagen fibrils provide a resistive mechanical force, thereby establishing a state of dynamic mechanical equilibrium within the dermal microenvironment. So the inherent mechanical properties will be a little protective to CC1 induced damage to the skin collagen. The interaction of fibroblast with collagen fibrils dictate the dermal mechanical microenvironment and fibroblast shapes. In aged skin, coalesced fibroblast activates many of the same cellular stress pathways observed in cells following direct UV exposure, leading to elevated expression of methyl metalloproteins, and reduced expression of collagen. Thus, fragmented collagen is a common driving force that mediates the convergence of many molecular and cellular features. So once the fragmentation of collagen starts developing, the process of aging becomes endogenous. Thus, dermal aging can be viewed as an outside-in adaptation, which is reversible by targeting the improvement in the composition, organization, and mechanical properties of dermal extracellular matrix. And this is all done by many of the cosmetic procedures which we are doing nowadays. Barrier dysfunction. The condition of xerosis, pruritus, and osteoporosis in aging skin, on the other hand, deserve special mention. These all are also the signs of aging and becomes quite problematic and common. The epidermal barrier is defected in aging skin and probably amount to all these clinical features. In addition, the ceramides that maintain the epidermal barrier are also thought to reduced in number because of reduced secretion. In aging, aquaporin gene expression is reduced, leading to poor hydration. In addition to the altered barrier function, results in increase in irritant and allergic contact dermatitis in aged skin. Photoaging and natural aging. The linchpin that connects the two forms of skin aging is the accumulation of cross-linked collagen fibril fragments. This accumulation leads to both impairment of the mechanical properties of dermis and reduced spreading of fibroblasts. Stressed fibroblasts have altered function, epitomized by less collagen biosynthesis and more production of collagen fibril degrading MMPs. The self-perpetuating nature of the process ultimately result in permanent collagen loss, clinically manifest as photoaging of the sun-exposed skin and natural aging of sun-protected skin. Implication of skin aging. It is easy to view the skin aging as pure cosmetic concern with many social implications. If it's measured on the basis of amount of money spent on the skin rejuvenation therapies and procedures, skin aging has a huge financial burden as well. The cosmetic implications. Many patients present with cosmetic concerns and are specifically anxious about the fine and coarse wrinkles, the skin laxity, the dyspigmentation, redness, telangiectasias, irregular textures, and dullness and roughness of their skin, especially the face. The concern applies to all skin types, with exception of redness, which is not seen in skin of color. Most of these concerns are attributed to both intrinsic and extrinsic aging. Numerous treatment procedures are available to rejuvenate skin damage and improve the facial aging. These therapies include several serums and creams. You can read about these in my lectures on cosmeceuticals, various non-ablative and ablative laser procedures. You can also read about this in my lecture on energy-based and devices and lasers. And these include IPL, LED light, radio frequency, CO2, and erbium jack. Other therapies to improve the skin, aged skin include PRP, the exosomes, stem cells, skin boosters, PDRN, soft tissue fillers, and neurotoxins. The social implications of aging. It's well established that youthful and attractive appearance is associated with greater success and opportunities in the workforce, increased social and sexual attractiveness, and overall happiness. That is why in the era of social media, the self-correction has gained lots of importance. Prophylaxis. Prophylaxis of aging is achieved by stringent sun protection with both physical and chemical means and stopping smoking. The mainstay of topical therapy for intrinsic and extrinsic aging includes retinoids. Further therapies you can consult in my lecture on cosmeceuticals. So thank you very much for patient listening and hope to see you soon with another edition of my talks. Thank you very much and have a very good day.